Good morning and welcome to the Calderdale and Kirklees Joint Health Scrutiny Committee. If I could ask members of the committee please to introduce themselves. So Councillor Hutchinson.
Councillor Colin Hutchinson from Skirkett and Calderdale.
Councillor Kingston.
Councillor Anne Kingston from Skirkett in Calderdale.
Councillor Lawson.
Councillor Joe Lawson from Crosslandmore and Neverton Ward in Kirklees Council.
And I'm Councillor Liz Smage from Bursell and Berkshire Ward, joint chair with Councillor Hutchinson of this panel. We have apologies from Councillor McKercher and we think possibly apologies from Councillor Evans and Councillor Robinson as well. Minutes of the previous meeting then. The minutes have been circulated with the papers from the committee meeting held on the 18th of March 2025. Has any members of the committee got any comments on the minutes of the meeting? No. Do we approve them as a true record then of the meeting? Thank you. Are there any declarations of interest that members need to make at this point in time? Councillor Hutchinson.
I don't have any pecuniary interest, but I am a member of Planning Committee in Calderdale, and there is an application from the Trust for the Calderdale Royal site that we will be considering in the agenda for next week. So I won't be able to say anything that might indicate any predetermination of that application.
Thank you. Anybody else got any interests? Right, thank you. If there's anything that comes up during the meeting, there is the form in the pack. Admission of the public, all items are to take place in public. Deputations and petitions, we have received one deputation from Jenny Shepherd, but she's not with us at this moment in time, so the scrutiny officer will read the deputation.
Thank you, Chair. So the deputation I'll read now. So the Kirklees Governance Officer's report proposes that Calderdale and Kirklees JOSC takes account of the information presented in the CHFT full business case reconfiguration report and considers its plans for future meetings and activities in relation to the reconfiguration. In these plans, please include the need for Kirklees Calderdale JOSC to be assured that there's capacity in the community services system to support reconfiguration of the two hospitals. This was required in 2018 by the then Secretary of State, Jeremy Hunt. Specifically, the Health Secretary required 1. Clarification of the programme for changes in out-of-hospital services, formerly known as care closer to home, and the likelihood of achieving the targeted reduction in demand for hospital care. 2. How the delivery of out-of-hospital care over the prolonged period of the hospital reconfiguration will meet the test for service change, and the out-of-hospital services will be in place before changes to bed numbers are made. The last time Calderdale and Kirklees JOSC seems to have raised this question was at the 7th of November 2023 meeting. It was agreed then that both place health, adult health and social care committees would come back in April 2024 with an update about this, but they don't seem to have. CHFT's reconfiguration update says nothing about assuring that there's capacity in the community services system to support reconfiguration of the two hospitals. Some questions about current CHFT bed capacity and occupancy. Why did CHFT only have approximately 780 beds open during 24-25? This was in the CHFT annual report 24-25. Were these overnight beds? Why did CHFT run bed occupancy regularly, near or 100% throughout 24-25? Again in the annual report, page 212. Why was trust bed occupancy 110% in April 25? 23-24 NHS operational planning guidance stated bed occupancy should be a maximum of 92%. Does CHFT agree? What happened to the planned 838 bed capacity in the revised strategic outline business case and the outline business case 2022? Although reportedly at the time of the outline business case, in 2022, only 808 beds were open. What is the bed capacity in the full business case? What about the fact that there are still problems with patients in hospital who no longer have a medical need to be there? Why have the planned new Calderdale Royal Hospital wards gone from 10 in the outline business case to 8 in the full business case? How has that affected planned bed capacity? What services have been developed in the community since 2022? Has there been a substantial reduction in demand for inpatient hospital care? What difference will the replacement of care closer to home by integrated neighbourhood health make? Even with the commitment to keeping bed capacity at 838 after reconfiguration, following an informal workshop on the 22nd of June 22 to discuss the outline business case, the 26th of October 2022 meeting of the Calderdale and Kirklees Joint Health Scrutiny Committee heard that council had expressed concerns around hospital capacity, clinical commissioning groups, redistribution of beds across the hospital sites, activity growth assumptions, staff and building capacity, community services, and the impact of care closer to home schemes on suppressing demand, which is key to safe hospital capacity. 3 years on, these issues have still not been addressed as far as I can see, and the whole context and provision of community and primary care services are changing unpredictably. Thank you, Chair.
Thank you. There are quite a few questions there for CHFT, which no doubt they will cover in their presentation. I just want to pick up about community services before we move on to the next item. Community services are run by different bodies in Calderdale and in Kirklees. And the Kirklees and Calderdale panels look at community services themselves. So what we don't want is the joint health having the same presentations as the standing panels. But as has been said, the joint health has to assure itself that there is capacity in the system. Kirklees panel has looked at community services. Councillor Lawson, do you want to say anything?
Thank you, Councillor Smage. We did indeed look at the community services with a piece of work and presentations by both the NHF staff and by Kirklees staff, where we actually looked at from hospital to home, looking at the discharge packages, what were the various different bottlenecks, and that was done last municipal year. We've also had a latest report is looking at winter pressures on is from both the hospital to obviously and the social care. So we do try to look at the joined up work, because any discharge, any sort of thing there, if one part of the system fails, then it all backs up.
Thank you. Councillor Hutchinson and Calderdale.
Yes, Calderdale Adult Health and Social Care Scrutiny Committee also considered this last year, but the situation in primary care and social care is very fluid, and as has been alluded to in the deputation, is changing in rather unpredictable ways, and I think it is still important that we should keep in mind the fact that this is a whole system change, that the trust straddles both sides of the M62, and that we need to be assured that there is capacity within the hospital system to deal with the needs of the community. I'm very aware that the elective recovery programme, to try and deal with elective care that has developed a backlog partly as a result of the pandemic, does mean that hospital beds are having to be used very flexibly. We need to know that will remain sufficient for the foreseeable future with the reconfiguration. I would suggest, Chair, that there is a lot of detail requested in this deputation. I think a lot of that is very relevant to the deliberations of this committee, and can I ask that we schedule in the near future a review with the Integrated Care Board representatives of both Calderdale and Kirklees as to the nature of the community provision and whether that fits with the assumptions made in the various business cases.
Yes, I agree, because there is a lot of change in the system at this moment in time, and we don't want the capacity issues that we need to look at being lost in those changes. And so I think we should, yes, have ICB representation at the next meeting. Is that okay with the panel that we do that? That's fine, thank you. Okay then, so we'll move to agenda item 7, which is the CHFT update on the reconfiguration and estate plans. So Anna, you leading on that one. Thank you.
Thank you. Yes, we shared a report with the committee to provide an update on the programme. Is that better? Yes, that's good. Okay, thank you. Apologies for that. My name's Anna Basford. I'm Deputy Chief Executive at Calderdale and Huddersfield Foundation Trust, and we submitted to the committee a report as requested to provide an update on delivery of the programme of reconfiguration. The report describes significant progress we have been able to make in relation to estate enabling schemes. I remind the committee that the new Accident and Emergency Department opened in Huddersfield in May 2024, and at the Calderdale site to enable the planned development of a new clinical building, we're pleased to say that we have completed the construction of a new learning and development centre, and a key enabler is the provision of a multi-storey car park, the construction of which is now in progress. Alongside that, we've also taken forward works within the existing hospital building, recognising that improvements will be needed around the main entrance, and also improvements regarding supply of electrical services to the main site. So in terms of the Estates Enabling Programme, we are on track to enable us, subject to necessary approvals that are required, and I'll come on to that, to be able to commence the build of our new clinical building in summer 2026. So alongside the significant estates works at the site, we've spent significant time to ensure communication with local residents, members of the public, and the full engagement of colleagues within the trust who have also had input into the finalisation of our designs for the new clinical building. I've described within the report that we are now in the final stages of the programme and are required to submit the final business case to NHS England and the Department of Health. We are on track to complete our preparation of that business case by the end of February and submit that to national teams for approval. Whilst we can't be definitive about how long that approval might take, we've been advised indicatively we should receive those approvals around July 2026, which, as I say, means that by autumn 2026 we will be in the final stages of construction around the new clinical building. So I think the report is self-explanatory. Myself and colleagues who are here today with me in relation to the reconfiguration programme would be happy to answer any questions. In relation to the deputation, I've noted the comment that you're going to have a further, more detailed discussion in relation to some of the points raised within that, but I can assure the panel that we continue with our commitment to maintain the overall number of beds across our 2 hospital sites that we committed to in 2018, and that remains the same. We have also tracked our occupancy and we have never breached that number, so it remains an adequate number of beds across the 2 sites. There will be an increased number of beds at the Calderdale Royal Hospital and we will require fewer beds at the Huddersfield site, but the totality of provision will remain the same. And the final, just general comment I would make on the deputation, there's a lot of interest in the development out of hospital. And I remind you there have been significant developments over the last couple of years in the community, not least of which is the development of a community diagnostic centre, which is now open in Halifax, and the planned opening of the community diagnostic centre at the Huddersfield University site in January 2026. Alongside that, we've implemented models of care out of hospital, such as virtual ward facilities and services for people, and also relocated services that were previously only available in hospital into community settings, such as the transfer of therapy services from Calderdale Royal Hospital to Dean Clough. As I say, if there are further points of detail required on the deputation, we can provide that outside the meeting. So I'll stop there and happy to take questions. Thank you.
Thank you. So we just need to clarify then the different stages. So the panel were invited to see the Learning and Development Centre, the new Learning and Development Centre, and we visited that and were impressed by the training facilities that are there. We've also been previously to the Huddersfield new build for the A&E, which is operational, as you say. So what we're waiting for now is the build of the clinical side of Calderdale Royal, isn't it, to be able to enable those changes in services to happen across both sites. Yes. And what's your deadline for those changes?
So I'm sure the colleagues may want to come in on this, but in terms of sequencing now, the multi-storey car park construction needs to be completed so that we can build the new clinical build, because we're going to build it on a car park, so we need the replacement car park completed. We're currently working to a timeline of summer 2026 for the multi-storey car park to complete, and it's making good progress and is on track for that. And that dovetails with our anticipated dates for national approval of the final business case. So at the moment we're working towards late summer, autumn period for start of the new clinical build and conclusion of that build in 2029. And it's at that stage that we will then be able to implement the managed transition of services from Huddersfield to Calderdale.
This committee needs to have assurance on how those reconfiguration of services, not just the build, but the actual reconfiguration of services is happening, and the communication, etc. And we've previously had communication plans, haven't we? And obviously the committee will, as time goes on, want to look at those in more detail as well. I'll open it up to questions then. So, Councillor Hutchinson.
Thank you, Chair. The maternity and catheter labs work that's shown on the timeline, has that actually begun yet? And is that separate in terms of the business case for that? Is that separate from the full business case for the development as a whole? So really asking when that is likely to come. Have you got an expected date for completion within 2026 of that work?
So I'll take that question if you don't mind. Stuart Barron, Deputy Director of Finance for the Trust. So that scheme, the cath lab and the maternity scheme are being delivered by our PFI partner at the minute. So there's design work undertaken at the minute. So it's called REBA Stage 4. It's the point we can go to market. We've got a preferred contractor selected, and we're just working through the final legal variation for that works. So that will take place in the next 12 months and will complete in 2026. The two separate schemes, they're subject to separate funding streams and subject to separate business cases, so not contingent on us developing the full business case that Anna alluded to earlier.
It's actually a totally separate question. But I was just questioning where we are with the status of the private finance initiative agreement under which Calderdale Royal Hospital was constructed, and for which particular has required some working around. So are you able to say where that agreement actually stands?
Sorry, can I ask just clarify the question for me? Specifically, what is it you're asking?
What are the plans to work around the private finance initiative agreement under which Calderdale Royal Hospital was constructed and the site kept in operation from 2000 or 2001 to now?
Okay, so thank you for the clarity. The Trust won't work round the contract, it will work with the contract for the remainder of its period, which is up till 2031. So as we work through the developments that we've seen, we will continue to work with our PFI partners on the site whilst we deliver the scheme. We can't work round the contract, but we'll work with it.
But that agreement comes to an end in 2031, does it?
Correct.
Can I just clarify then? Does the whole agreement come to an end in 2031? There isn't a continuing agreement for the areas of new build. That is separate, I take it.
Correct. The new clinical build, as we've previously provided assurance to the committee, is not under a PFI agreement. The current PFI agreement was a 60-year contract, and with break clauses within it. The first break clause is at 2031, which the Trust is committed to, and therefore the PFI contract will end in May 2031.
Councillor Kingston.
I didn't hear that last point before I go on to my questions. I'm sorry, my hearing's not brilliant, and your mic wasn't very close. Are you saying that there's PFI on the new build? No, there's no PFI on the new build. No. So it doesn't affect it. So everything, all the PFI is completed in 2031.
Correct.
Oh, that's good news. Thank you very much. My question was two questions. Just 3 years? Why is it going to take 3 years? That seems like a long time compared to how long it took to get the learning centre. So that's it. Why is it going to take 3 years? Why is it such a long time? And then the other is Jenny Shepherd's question about why have the planned wards, number of wards, gone down from 10 to 8? What's happened there? I'm new to the committee. I apologise if this has been covered previously.
I think I'm Mark Davis. I'm an A&E consultant and a clinical lead for reconfiguration at the Trust. I think the reason it's going to take 3 years is because it's huge. I'm not 100% sure on the footprint of the learning centre, but certainly the new A&E at Huddersfield was about 1,500 square metres. This is 25,000 square metres. This is a 4-storey building which covers a significant proportion of the site. It's a very, very big construction project. So that's why it's going to take 3 years. In terms of the change in ward sizes, our REBA 2 design, which is the initial design we had when we got our construction partners on site, was for 10 wards of 24 beds. They came and they gave a different slant on the design and gave us a more economical building, a more energy efficient building, and we were able to take a floor off the building, which then has a financial impact, which is beneficial, as well as construction benefits. So we've now got 8 wards of 28 beds. So we got bigger wards, but less of them.
Can I ask then about the maternity floors, because you're planning to commence in autumn of this year and complete next year. So is that still on track to do that reconfiguration of those maternity wards?
Yes.
When you are, can you clarify for me that we seem to have been at this a long time. Yes. You are saying that the new build of the new building will be ready in 29. So if the new build of the new building is ready in 29, how long then do you expect the movement of services across the two buildings to take? Are you still expecting that movement of services to be in 29 as well?
Like I said, it's a big building, it's a big change. It's the transition is not going to happen quickly, and we'll need to do it in a monitored and measured way. We haven't got any detailed plans for transition yet because it's still 3 years out, but we will start transitioning as soon as we can safely move into the building. We'll have to take into account operational pressures. For example, it's going to be a winter in the middle, and it may be that we have to do some transition before and some transition after, just because of the pressures on services. But we're in the process of developing a transition plan at a high level, and we will refine that as we go forward. And I'm sure that as time progresses, we'll be able to update the committee in line with those plans.
Just want to clarify, because I'm sure some people who've got good mental arithmetic will be able to work out that 10 wards of 24 beds is 240, 8 wards of 28 is 224. So there is a difference of 16 between them, which seems to, I mean, what's 16 between friends? But, you know, I'd just like some clarity, given the assurances that we've had that the overall bed numbers are going to remain stable.
Yes, we asked the same question of ourselves. And at the same time as we were making those decisions on changing the form of the building, we had a review of all bed spaces in Calderdale Royal Hospital, and we were able to identify a number of bed spaces that weren't being used as bedrooms, sort of converted into office restrooms. So we've been able to repurpose those as bedrooms. So the overall number of beds at Calderdale Royal will remain the same, and our commitment across both sites will remain the same.
And can I just ask regarding the maternity floor? My understanding is that there will be 2 dedicated theatres to maternity. Are those in addition to the 8 theatres that are in the main theatre block, or are they repurposing of two of those? Are they completely new theatres?
They're additional ones. So currently there is a theatre for obstetrics, and we will be a +1. So the 2 new ones will be dedicated for obstetrics. That will be in addition to 8 theatres that are currently at Calderdale, and we're currently looking at a potential 9th or 11th, depending on where you add them. So there could be 11 theatres on Calderdale site going forward, but the 2 maternity ones will be for obstetrics.
Can you explain for me what the National Infrastructure and Service Transformation Authority Gate 3 review consists of, please?
Hi there, my name is Fran Hewitt. I'm the Assistant Director of Transformation and Partnerships. So the NISTA, as it's now known, used to be known as the IPA, Infrastructure and Projects Authority. So you may be more familiar with that terminology. So during the process of developing and realising the business case with the Treasury, there is a process that we follow with gateway reviews. So We are heading to Gateway 3, so we successfully completed Gateway 2 at the outline business case stage. The Gateway 3 process is to provide our SRO for the project, which is our Chief Executive, with some external assurance and expertise and guidance and recommendations around how we're progressing through the planning and delivery of a major capital project, and the team that they provide from the NISTA assessment process will give us recommendations based on what they've identified through that process. The process itself reviews some of our documentation that we provide, including some of our programme management documentation, the business case itself, and anything else that they deem relevant in relation to how we're delivering the programme. And they undertake a series of interviews with key stakeholders from the organisation and from the ICB and NHS England, who are part of that process to help us to get through to the next stage of the business case. So that process takes place prior to submission of the full business case. And it will support us in then taking forward the implementation of our plans.
So I notice you've got the Gate 3 review in February and the submission of the full business case in February. So how is that timeline going to work with the with any recommendations, with the review reporting to yourselves on recommendations, and then those recommendations being actioned before the full business case goes in? What is the time that you've allowed to be able to do that, and is it achievable?
Thank you. So the process that we go through, so we will undertake the Gateway Assessment Week. It usually takes 3 to 4 days, with an assessment team from NISTA. They provide real-time feedback at the time. We are not anticipating that we will have any major conditions or recommendations. We have a good ongoing relationship with the Department of Health, NHS England and NISTA, so that we understand our progress throughout the year. And this is more of a wrap-up of that and gives us a bit of a assurance and any actions that we can take forward to go from, I suppose, what I'd call good to excellent in the areas that we're working on.
And do you have a definite assurance that your July 26th for the approval of the full business case can be achieved, going through the different areas of that it needs to go through? Is that definitely achievable?
I can't give that definite certainty because it's reliant upon processes within Department of Health and NHS England. However, we've asked Department of Health and NHS England how much allowance we should provide for national approvals, and they've said circa 10 to 11 weeks following submission. So that's what we're working on. So our absolute date we're working to is that we will be submitting at the end of February.
Thank you. It's just, you know, experience that, yeah. We've had delays before, I think, in these things. All right. Councillor Hutchinson.
In the meantime, while the focus is on the Calderdale Royal site, obviously there's another District General Hospital site over in Huddersfield, and I was wondering what the maintenance, how the maintenance programme on that site was panning out.
So the Trust continues to invest some of its capital resources into Huddersfield Royal Estate, and continues to do so. We go through an annual capital planning process that identifies the key areas for investment that's advised by our Head of Estates. We've done that again this financial year, and we continue to invest in it to maintain the estate going forward. So we continue to do that. We're also starting to work through what the estate will look like going forward as post-reconfiguration as well. So we've got the eye on the longer-term commitment as well.
So the key areas for investment in over the next 24 months on the Huddersfield site are?
We're continuing to invest in ensuring our roofs are watertight, our pipework is replaced and up to standard, our electrical infrastructure is maintained, our building management systems is maintained and enhanced where it can do. We're also exploring moves some of the green technology, so solar panels and LED lighting has been installed throughout, but we're looking at solar panels for the estate. So it's a balance of managing compliance whilst trying to make sure the estate's fit for the future as well.
I can remember arguments that it would take millions of pounds to upgrade the site at the Huddersfield site. So all that you're doing within your budgets to maintain the building, is that just maintenance of the building, or is it improving the building? Because you said as well that you would look for the site configuration after reconfiguration. So is it a holding position on what is there, minus the new A&E facility? Or is it trying to put right all the list of items that were mentioned quite considerable time ago that were needed at the Huddersfield site?
So I think there's probably a balance of two things in there. So currently, our capital focus is to maintain the estate in its current condition. So we are doing pipework replacements, electrical infrastructure replacement, enhancement of building management systems as examples. That will be fit for the future for the next 60 years. The building's 60 years old and we're replacing pipework from its original state. And the point around some of the other battle maintenance challenges that HRI has is in relation to some of the conditions of some of the wards, and we can't do those refurbishments and ward and window replacements and cladding replacements whilst we're in our current configuration. When we've reconfigured and the capacity, the patients that we treat have moved over to Calderdale, as Mark's described, when they've transitioned over in 2029, we'll have excess capacity on the Huddersfield site. And therefore we'll be able to say, right, that ward can be closed, we can take it out, we can strip it back, we can replace the windows, we can give it a full refurbishment, we can move the patients back onto that ward, now it's lovely and shiny and new, and we can do the next one. And that's the flexibility that the reconfiguration will create, and that will allow us to transform the estate as opposed to maintain it.
Awesome.
Thank you, Chair. Is in the actual report, you're actually stating that there has been investment to upgrade wards and theatres. From what you're telling us now, it seems that Huddersfield Royal will be waiting till after everything has been done at Calderdale.
So there has been investment in some of the wards. They're just not all the modern standard we'll get to over periods of time. So a few years ago we refurbished Ward 18, and that was done in 2019 from memory. We don't have the capacity on the estate to free up a ward and leave it vacant for a 8-month period to do a refurbishment. So once we've got the capacity, as I described earlier on, then we can do those refurbishments. So it's not that there hasn't been investment in the estate. We don't have the ability today to take that ward out. The reason we had the ability to do it back then was COVID. So when the COVID numbers, when COVID hit and the capacity in the hospital dropped significantly, there was the ability to do that. So that's what we did. We took the opportunity.
So you're saying that in 2019, Ward 18 was upgraded. Is what work was actually done during COVID? Because from memory coming back, that was sort of March 2020, when obviously hospitals started to close down to elective surgery and things like that. So since then, what work has actually been done at Huddersfield Royal?
Forgive me, because Mark's just pointed out it was 2020 when the Ward 18 refurbishment done. That was a full refurbishment back to brick, rebuilt and made nice. And it was created as a single occupancy room, so it helped with infection and control and COVID. Since that point, we've continued to invest in the estate. But as I said earlier, we're doing replacement of pipes, electrical infrastructure, building management systems. So it's not transformation stuff that a patient will typically see. It's making sure that the buildings continues to operate is what we're doing at the minute.
Thank you for that clarification. Is obviously there is a lot of background work going on, which the patients, as they walk through walk into Huddersfield Royal Infirmary, don't actually see, but is at least we know that going somewhere down the line that there will be investment into the wards that remain at Calderdale Royal.
Yeah.
Huddersfield Royal.
And forgive me, we did bring something to this committee 12, 18 months ago that described that over £20 million worth of investment into the Huddersfield Royal Estate over the last few years. So it might be worth digging back to them papers to provide the assurance that you're seeking.
I seem to remember it was quite considerably more, was the estimates when we were talking about some time ago now. It was considerably more than 20 million that was needed at HRI, which was why we are asking the questions. I think it would be good if you could let us know, please, when you will have the configuration plans for the Huddersfield site in place, so that we can look at those in detail, so that we know exactly what work and how it's going to be financed will take place at HRI.
We'd be able to come back to you in a response to that, but I think at this stage, I think you'll recognise we're very focused on finalising the plans and submission of the full business case in February, and that's where our technical planning and attention is at this point in time. Clearly, those developments on the Huddersfield site are reliant on us having transferred services to Calderdale Royal Hospital to give that flexibility. So what I'm saying, we have a bit of lead time. We're not going to leave it until 2029, but I think it will be after we've submitted the full business case that we will turn the attention of our teams to saying, let's really get a detailed plan together around the Huddersfield. That's not a lack of commitment, it's just us phasing the necessary inputs across the programmes at the right times.
Okay, thank you. You wanted to come in, sorry.
Sorry, hi, I'm Lindsay Rudge, I'm Chief Nurse. Fran's going to follow it up in a briefing, but we did also invest in our oncology area. We upgraded one of our wards to be able to deliver the new non-surgical oncology pathway, and also the integrated hub at Huddersfield, which was our old emergency department. So we've created a discharge lounge, a technical information centre, and we're able to stream people differently through that service as well. So there were some additional upgrades that we perhaps can put in some more detail around the other areas additional to Ward 18 that we've upgraded and invested in. So we'll add those into an additional briefing that we'll send through, so it just makes clear all the totality of that at Huddersfield.
Okay, thank you. If you could let us have the information when you can, please, because it was millions and millions of pounds that were needed some time ago, and I realise that there's ongoing maintenance and there's reassessments, etc. that happen, but there was a lot of work needed on that building, and I think we need to be able to see the plans as they move forward. Okay, on that one. Are there any other questions on this particular item? No? Okay, thank you very much for that. Obviously, the full business case is the next milestone, and therefore we have discussed how we can look at that without breaching contractual integrity. Okay. All right, thank you very much. We now move to the item 8, which is on maternity services. So who's going to lead on maternity then?
Hi, thank you. I've already introduced myself. I'm Lindsay Rudge, I'm Chief Nurse, and I'm here with the Directors of Midwifery, I'm here with the Directors of Midwifery, both from Mid Yorkshire's Teaching Hospitals Trust and CHFT as well. So we've provided a comprehensive paper updating on the current position across both trusts in terms of workforce, birth choices and the services currently delivered. And we've also updated around the birth centre at the Bronte Birth Centre, and I'll let the Directors of Midwifery provide any more detail that you may want that's detailed in the report, and we'll be happy to take any questions. Thank you.
Good morning, my name's Kerry Reedfield. I'm the Director of Midwifery, Children's Nursing and Women's Health at Mid Yorks. I think the key thing since we last came to the committee is the formalisation of stopping intrapartum births at the Pontefract Birth Centre, which was a decision made by Wakefield District Health and Care Partnership in September. Beyond that, I think I can take the paper as read, and I'm happy to answer any questions that you might have from that.
Good morning, I'm Gemma Puckett, the Director of Midwifery for CHFT. Again, take the paper as read, and I think the key areas for us to update on our ongoing progress around our workforce. In August 23, we had a circa 30% vacancy position. In October, we anticipate that to be 3.5%, so we've made a significant improvement in our midwifery recruitment and retention of those midwives. That has had an impact on our skill mix with a more junior workforce, because the bulk of that recruitment has come through newly qualified staff that we're supporting. The preceptorship programme is a 12 to 18 month programme, so we are some way into that from those we recruited last October, with a further output of staff in April. I wanted to provide committee with some assurance around offer of birth choices, and we have a cyclical information sharing programme on social media, and within that we include the offer of the use of the Bronte Birth Centre, as well as leaflets providing information on birth choices and discussions throughout pregnancy at the point of risk assessment and birth planning as well. And then I think our offer of antenatal education has been expanding, and we have several virtual offers now which are proving very popular with families as it helps them engage at a time that's convenient to them, but also delivering some sessions through the Huddersfield area through the hospital, with the plan to roll further sessions out. We're just working with Kirklees Active Leisure at the moment around the possibility of delivering some antenatal education through their services. We have an opportunity when the CDC opens in Huddersfield to look at what we can deliver through the CDC to communities, but also working with community leaders and arranging to meet with one of the leaders from the mosques about what we can deliver through those facilities as well, so developing our antenatal education offer. And to highlight to committee that our priority for our services will be closing the gap in health inequalities and improving the outcomes and experiences of our women and families, and working towards a delivery of a continuity of care model to enhance that. Happy to take any questions.
Are there any questions on this? Councillor Hutchinson.
Thank you. The data on the vacancy levels is on quotes people who are actually in post, but we know that there are going to be vacancies, well, that number doesn't reflect midwives who are on maternity leave or on long-term sick, and I was wondering what the real deficit in staffing levels actually is, rather than the theoretical.
So we will always have a level of maternity leave as a predominantly female workforce and a younger workforce. We anticipate that to continue at the levels we see currently. We do backfill through temporary staffing, so use of bank staff, which are usually staff that are very familiar to us. We very rarely use agency staff in maternity services, and we've been working with our colleagues across finance to increase our recruitment position to permanently backfill to a degree of that maternity leave that we see on an ongoing basis. So we're working with colleagues to over-recruit, if you like, against our baseline establishments, that we've got a permanent backfill of a degree of the maternity leave that we see. But yes, it is a challenge sometimes. The backfill for maternity, for midwifery, because of the banding the rules are held at, is difficult, because people don't often leave for a temporary maternity leave cover. They will leave for a substantive cover or come and join the organisation for that.
So we always work towards a zero vacancy position, whether that's midwifery or nursing, and to do that we take into account the maternity leave that we both know historically and what we know about going forward. So the plans are always on that. We've got detailed data that looks at our number of leavers per month, whether that be in midwifery or nursing, and again we plan on that basis. The limiting factor is the recruitment cohorts as they come out. So the maternity recruitment is still centralised through the local maternity and neonatal system. But we've been working with the national team, and the national team has made a commitment that no graduate will come out of their training programmes without roles, and we've created some additional posts at CHFT to make sure that whether you're a midwife or a nurse, that there's an offer of a post, and we are part of that national response at CHFT.
Yes, I mean, you've pointed out how the 2022 and 2023 cohorts of newly qualified midwives have been accommodated within the trust. What about the 2024 cohort? Because there's a strong likelihood, following the National Maternity Services Review, that the amount of statutory mandatory training is likely to increase, taking people away from actual delivery of hands-on care. How much is that factored in to what the offer to this particular cohort of newly qualified midwives?
I think just to add in addition to what's already been said, that there is an uplift, not just to maternity leave, but to sickness that we have within our establishments. So it's we over-recruit to encapsulate that. There is a national review of training and the amount of mandated training within maternity services. And as part of our birth rate plus assessment that we do twice yearly, but with the external birth rate plus organisation 3 yearly, that takes that into account. And at Mid Yorks, we are in an over-recruited position. We recruit to turnover. We were fortunate to be able to offer all our graduates a post with us, and we actually had a waiting list of people who were keen to come and join us within the organisation. And as colleagues mentioned, the guaranteed offer for new graduates, we've been in a position to take a further 2 newly qualified midwives in addition to the 7 that we're over-recruited to.
I mean, I'd like to congratulate the Trust on its attitude to recruitment of staff. Your figures don't actually say much about the other side of the equation, which is the retention of experienced staff within the service. What is the picture of that at the moment in terms of stability and retention of staff, and are there any particular themes as to why staff may actually be leaving the Trust?
And so we have at CHFT had an improving picture around retention, and that was some of the challenge we did face previously, was a high turnover of midwifery staffing. The themes of people leaving, so you mentioned the 2024 cohort. We have had some of those new graduates leave, but we also have met with them and we've had very positive feedback about their experience with us, but they were commuting from distances. Some were coming from Thirsk, some were coming from the other side of Leeds. So we were aware that out of that large cohort we took in, we may lose some of them to more local organisations as jobs became available due to the commute that they had, but we had worked with them to manage their rosters, to make that as palatable as it could be for them whilst they worked with us. But they've left us very positive feedback. So that retention picture has improved and improved with experienced staff. And in the 2 years that I've been in the organisation, we've actually seen staff who've left come back to us. So we've had a picture of people perhaps thinking another organisation may be preferable and returning to us as in a positive way. So that retention picture is improving. Our focus will continue with recruitment, but is much more now around what's our offer to those staff who work for us, progression and professional development offers, and we've invested significantly in training for staff around leadership, around advanced clinical skills, around different programs that they've wanted to undertake, developing career progression programs through from our maternity support workers through to being senior leaders in the organisation, shadowing opportunities, so really having a focus on what do we do for our existing skilled staff to keep them interested, looking at legacy posts across the organisation and how we utilise that experience of people who may be considering retirement and perhaps don't want to work that full shift pattern but have got lots to offer to us. So lots of work going on around retention, but it definitely has been an improving position with returners to us who'd had left previously.
I think, as you rightly point out, there are different changes around those training demands that, and we're forensic at both trusts. I think, Kerry, I can say that, you know, where Kerry's mentioned twice yearly reviews, that goes to the board of directors. We look at the data, we analyse that in terms of numbers of colleagues, but also the headroom that is built into what are called their electronic rosters, which are how we make sure we've got the people with the right skills to meet the services, and that does include their training allowance that is built into those. We review that, and we're just in the process again of reviewing that, so we always take into account any national changes that come through with mandatory training, so that will go through a paper which is called our Safer Staffing paper that goes through to the board of directors. It includes maternity.
I think just to add to that as well, I think from that ageing workforce that we have, the fact that we have flexible contracts that support colleagues to stay and keep that experience and that skill mix within our teams is really important. After saying that, we do need to be mindful that training within maternity services is considerable, and that's per head of midwife. So a midwife who works, say, 20 hours a week will have the same amount of training than somebody who works full time. So it's that fine balance as well that we need to take into account. But that's something that we monitor within our staffing levels.
Can I ask, we'd asked previously about future capacity and how you work out what levels of staffing you need going forward, and also it affects what space in hospitals is required. And with the changes that are happening for the maternity floor in CHFT, and you've also alluded to Pontefract, so there'll be extra capacity presumably needed in Pinderfields, which then has a knock-on effect as to the capacity available for North Kirklees ladies to go to Pinderfields. How do you work that out moving into the future? Because we asked that previously, and I still don't think we've really got a handle on that, because surely you do. I mean, I know it is choice, and ladies will go to Leeds, Bradford, Barnsley, they go other places. But how are you working out that you have the staffing and the space into the future?
So that is part of the Birth Rate Plus assessment. That looks at a period of 3 months of what our activity is. So it's looking at the types of care that we're delivering, whether it's low risk, that more complex care, or whether it's a theatre delivery, caesarean section. So that's a way of looking at the number of midwives we need to provide our service. I think in addition to that, we know that the birth rate figures are reducing, but what we are seeing is that increase in complexity. And I know from when the Pinderfield site was built, we've got 500 less births taking place. So from a capacity perspective, we are able to absorb that, and we haven't seen any issues in the 5 years that we haven't been providing intrapartum care at Pontefract. It hasn't been an impact on our service provision there. But conversely, you know, we work closely with external stakeholders and looking at developments of houses and things like that within our local communities to see potentially will that have an impact, and that's ongoing review to make sure that we always have that capacity within the service.
So similar in terms of trying to model birth prediction data, looking at developments in the area that may bring families in, etc. It's not an exact science for trying to predict your future birth rates, but we would also look at the data around length of stay. We have monthly data that comes around type of birth, operative delivery that would impact on length of stay, care management pathways, so enhanced monitoring of the newborn baby, etc., that might enhance length of stay. So we would combine those things together to review our capacity. At Calderdale site in particular, we have opportunities moving forward to look at how we configure our maternity wards, so taking into account patient experience, so things like partners being able to stay overnight on the ward areas if wanted. Currently our bed spaces are limited, but we may have opportunity to review that differently. So capacity, due to the reduced birth rate, our bed numbers have not changed. The complexity of the women and families using our services has, resulting sometimes in a longer length of stay, but that is all built into our modelling. The workforce then, with birth rate plus planning, looks at 3 months of that activity, but obviously that's in the moment, so we would take this additional data around type of birth, length of stay, etc., to inform with professional judgment what we think our workforce needs to look like moving forwards.
Okay, I'm confused. So I don't want to go through conversations that were had quite a while ago about Mid Yorkshire's configuration, because we had concerns at that point in time about the health inequalities in North Kirklees that could lead to more complicated pregnancies, more complicated births. My confusion arises in what you've just said about CHFT, because there's active work at CHFT on changing the reconfiguration of the maternity layout. So what you said, I think, was that about the capacity and the complication changing. So does that mean that you're going to put the standalone birthing centre next to the obstetric-led care at Calderdale? So are you saying that those spaces would have to flex as complications change, if complications get worse, or complicated births reduce?
So our plans around reconfiguration are not to change those spaces. The birth centre at Calderdale is an alongside birth centre because it is located on the same site as the labour ward. We are just moving the location of it within the organisation to the same floor, and therefore alongside the labour ward, but the number of birthing rooms available in that will remain the same, and the criteria for using it, so low risk midwifery-led women predominantly, will remain the same. We would not plan to flex that space would become an extension of the labour ward. It will remain an alongside birth centre with that principle and philosophy applied to it. The capacity on the labour ward will be remaining the same as well, so the same number of birthing rooms as we have now. So the reconfiguration of those services is not changing what we do with them currently, it's just relocating one of them onto the same floor.
So like Mid Yorkshire, our birth rate has decreased over the years. We're not changing our capacity in that service. And what Gemma's describing is sometimes that means that women stay longer in that area before they go home. So therefore we won't be reducing the capacity. It's the different presentation of women that's changing. and we're not changing the birth centre to accommodate for that. The birth centre will remain at Calderdale as it did. So the capacities remaining the same. We're just describing that women that are coming through the services have different presentations.
Okay, so I'm still a little bit confused. So what you're saying is women are staying longer, but the birth rate is reducing. So one helps the other. Is that what you're saying? So that the actual capacity remains the same, but women are staying longer, but there's less women coming in. Is that?
Yes, that's correct.
That's
yeah.
it. Right. Okay. I think I've got that. So can you then tell me then how you are informing? Because this was a key question we had last time. Where are you in informing people about the different options so that women are fully informed? Because I noticed from your report that you say CHFT continues to collaborate with colleagues at Mid Yorkshire to establish pathways. Now, are those pathways already in place and working and operational? Is it just that the report should have indicated that they are established, or is there still work happening, and what are the conversations and the information that is being given to all women so that they know the choices, and how is that being presented to them so that they have informed decisions?
So we provide written information to women on the birth choices available to them, but more importantly, we discuss those birth choices at appointments with women about, depending on how their pregnancy is progressing, their choices, what they've expressed they may be interested in, is discussed throughout their pregnancy, with usually formal birth plans created around 36 weeks. We then have other mechanisms of sharing information such as social media, and we include sharing information about the Bronte Birth Centre on that. We do have established pathways for referrals between services, so if women were choosing to use the Bronte Birth Centre, we will make referrals to the Mid Yorkshire Trust. The bit that we're continuing to work on, because we're on different electronic patient records, is how do we ease that, and that's a wider piece of work that's going on around the Yorkshire Care Record and how we can share information more readily between organisations rather than full rebooking, etc., so that there is better information sharing agreements where we have different EPRs. So that is a continuing piece of work across the LMNS, not just with ourselves in Mid Yorkshire, but with the other organisations within the system as well.
So straight from the first booking appointment, women and birthing people are provided with a personalised care booklet that has all those options. That's written information supported by the discussion with midwifery colleagues. There is that risk assessment throughout the whole of the pregnancy. So at each point of contact, there is a review of intended choice of birth, place of birth is still appropriate. So that's monitored right the way through to the ultimate birth plan assessment that Gemma just alluded to there. I suppose what having the 4 options of birth environment supports us with is the increased number of women that are choosing to birth outside of guidance. So we have an additional clinic to support women with those birth choices to make sure that they're making a fully informed decision with the MDT for their choice of birth, and actually having the multiple different options of where to deliver their baby supports that dialogue to minimise the risk to both mum and baby.
Councillor Keys, did you want to come in?
Thank you very much. As I said before, I'm new to this committee, so I'm not up to speed on everything. So excuse me if I ask anything that's already been asked at a previous meeting or is in hand. I would note as well that Councillor Hutchinson has already asked the main question that I had prepared, which is quite normal in my experience. I'm just looking at the health inequalities stuff, which I'm particularly interested in. I know that there's a significant issue with inequalities in outcomes for women from different ethnic backgrounds, and particularly I know that black women in the UK are more likely to experience infant mortality at birth. And I wondered, has the committee seen local data relating to health inequalities regarding ethnic minorities, people from ethnic minorities? Have we done, excuse, this is my own health issue, have we got comparative data about that? And do we know what Calderdale, which is where I'm from, but the CHFT, what we're doing about that to address that?
So we have lots of data on the outcomes of our families, and including breaking that down by health inequalities, which we report through our governance structures and into our board of directors, also into ICB quality forums, and we go to those every 6 months to update on progress and where we're at. It is fair to say that across Calderdale and Huddersfield, we do see that disproportionate representation of women from a black and Asian ethnicity represented in our data with poor outcomes, particularly stillbirths. And we've been doing lots of work to try and address that. It reflects the national picture in terms of those health inequalities. So we are trying to target some of the work that we're doing to improve those outcomes, particularly for South Asian women, because that's been the data that we have seen, and particularly looking at postcodes and wards that we see those women living in areas of deprivation. So we've got various work streams ongoing to address health inequalities that include things around access to care and navigating healthcare. So some of the actions we've been taking are around supporting with transport costs and working with our colleagues in local authority to provide bus passes, and we're just about to roll that out and going to pilot that as an option. Open access to our urgent maternity assessment services so that women can arrive as they would do with ED if they have concerns. We're currently just about to finalise some videos in our top 5 languages about what to do if you're worried about your baby's movements, so that we can share that with local communities. I've alluded to the working with community leaders and our local religious leaders to try and deliver care perhaps in those areas where we may access people who are less willing to come forward through the forums such as the Maternity Voices Partnership, who we work closely with. An example in Calderdale is our MVP chair has been working with St Augustine's and has been visiting and regularly one of the hotels that are providing support to families seeking asylum to get their experiences of care. And we've also developed a maternity befriender role, which is a non-clinical role to help women support navigating healthcare and providing additional enhanced support to them that we've been recruiting to recently. But we've got some other mechanisms ongoing around helping us identify vulnerable women, so outside of ethnicity and postcode, but those who may be socially vulnerable and have social complexity. So a tool that assesses that and will flag in our clinical records, and having a programme of enhanced care around those. The priority for us as an organisation is to get continuity of carer up and running, again for vulnerable families, because we know that is what will make a difference, building that lasting, trusting relationship. But it's really important that there's a piece of work around this that is outside of maternity services control, that preconception bit, childhood, family health care, so working with our colleagues across Calderdale and Kirklees in the Starting Well programmes, about how we educate families, owning your health as a young person, coming into pregnancy as healthy as you can be, so working with our primary care colleagues and various stakeholders. So it's a long-term piece of work to close the gap in health inequalities, and it's more than just CHFT who can address that, so working closely with colleagues to try and make a difference with that. We are just about to recruit to a consultant midwife post whose portfolio will be supporting the reduction in health inequalities and improving public health. Mid Yorkshire have that post in place that's recently been recruited to as well. So as soon as we have our consultant midwife, they will be working closely together across the Calderdale, Kirklees, Wakefield patch for some joint pieces of work as well.
I think just to come in there, I mean, health health equity is very much on the Trust's agenda. We have a separate dashboard that relates to maternity equity items. I mean, Gemma referred to our consultant midwife, which has come from national funding. Unfortunately, it's not recurrent funding as yet, so that's something else I'm working on to do that, but it was very much focusing on health equity as opposed to health inequality, because we're very much aware of the global majority and the poorer health outcomes, but obviously looking in the locality, the families within the lower deciles of deprivation and making it more meaningful for them. We've also seen the benefits of the Befriender programme, and with some further monies we've now in recruiting to expand on that to look at those more vulnerable cohorts within the community, but also looking at digital poverty, and we're part of a pilot there that we're providing telephones and SIM cards to make sure that there's more equity again for the women during accessing our services. So I think it's very much on the forefront, and I think the collaboration when we get both consultant midwives in post will be able to get even better outcomes than what we've achieved so far.
Councillor Hutchinson.
Continuing on the theme of the high risk pregnancies and deliveries, I noticed from the Trust Board papers in July that there was a relatively low rate or high number of bookings by 10 weeks of gestation, so reducing the ability to identify and address general health problems in the early stages of pregnancy. It said that there was going to be a deep dive into those figures and whether there were changes in practice that needed to be addressed. I was wondering where that had got to.
So we have looked at that data, and we've broken that data down, looking at health inequality, which postcodes do we see there, where women present, and we know that is the same cohort of women who are perhaps experiencing poorer outcomes are also the ones who are booking later in pregnancy. Part of the deep dive was to understand what data we need to extract out. So that data of booking by 10 weeks was including those who've transferred care to us, so perhaps moved into the area or decided to change organisation. So the piece of work we're doing now is to build a data set where we can filter it, and we can truly see those who are presenting beyond 10 weeks, who live locally, versus those who've transferred into the area beyond that point, and we would never have had the opportunity to book. We've been part of an LMNS, local maternity system campaign about presenting early in pregnancy called Speak to a Midwife. And we're working with our GP colleagues. So we've got an educational event with them in January. And part of our presentation that we're going to do is around what they can do to help women present earlier in pregnancy. Part of the work with the community leaders is overcoming some of the barriers as to why women don't. There is some historical, cultural practices around not wanting to present early because they don't want to tell people they're pregnant, around beliefs that they may miscarry if they declare their pregnancy earlier. So there's some of that work we want to do to myth bust, if for a better term, around presenting early in pregnancy as well. So supporting perhaps having the generic campaigns, but actually then having really targeted pieces of work around encouraging women to come forward. The maternity befriender rules like that are part of that process, but definitely engaging with colleagues for the preconceptual bit around what they can do, opportunistic discussion with women who may be seeing their GP for other reasons, etc.
Yeah, you know, along the same kind of lines as it's being done to try and improve the general health of people who are embarking on potentially curative cancer treatment. It seems a good opportunity to try and maximise the health of women prior to delivery, to try and address that, reduce that stillbirth level. And can you say a little bit about the staffing plans for neonatal nursing services, because that seems to have been another area of stress. Particularly the levels of staffing of people who are actually qualified in neonatal nursing.
So the neonatal nursing workforce has been challenged, and we have undertaken a review with the neonatal delivery network. We undertook a review of our cots, neonatal cots, the configuration of those, so the number that were intensive care, special care and high dependency care, what our activity data was showing us around the usage of those. So we've done that piece of work, and that has then informed what nursing workforce is required to run that level of cots in a similar way that you would do with an intensive care service. There's very prescriptive ratios of nursing workforce to cot configuration that you require. So we've done that, and as a result of that, identified the shortfall that we had, submitted a business case which was approved and been funded, and we've been out recruiting to make sure our neonatal nursing workforce meets that cot configuration requirement, and we've successfully done that, and we've got 10 full-time equivalent neonatal nurses starting in post over the coming weeks, and that will take us up to our full complement of neonatal nursing. The other element to that is then qualified in speciality, which is an additional qualification for them to provide intensive level care. That has been a challenge regionally and seen nationally, that there is a shortage of qualified in specialty nurses. It's quite a long programme of training, and so getting people through both parts of the course, you can only send a few people at a time, so it requires them to be released, so we've got a rolling training programme, we've got funded places through the ODN, and our current position as of September was that across our whole neonatal workforce, we've now reached that minimum level of 70%, so 72% qualified in speciality. Actually in post, excluding the maternity leave, it's now at 65%, which is an improvement. So with the rolling programme over the next 6 to 12 months, we expect to meet that minimum requirement of 70% with those actually at work.
Sorry, a similar position. We've been doing some work with the ODN to look at that. We had some roles such as nursing associates that were within the establishment, but they don't actually contribute to the BAPM safety, safe staffing tool. So because of that, we've undertaken a process of amending those vacancies that we had in nursing associate and transfer and bridge those across to nursing posts. So we do have a gap of, I think it's 5 nurses that we're just in the process to go out to recruitment for. Again, the qualified in specialty can be a bit of a challenge. We're part of the programme, so we send on every programme a set number of nurses to do that. We are actually at the number, although for next month we will drop just below it because we've got somebody who's moving out of area, and it won't be till the next programme that we can get up, but we mitigate that with the close scrutiny of our staffing model.
Is the neonatal nursing programme delivered from Leeds Beckett University, or is it from Huddersfield University? Where is the training actually based?
So there are a few universities that offer the qualified in specialty, so it depends where the ODN have got funding and places allocated with. But what we do is work collaboratively across the system around the placements to support the practical element of the training. So some of our staff, for example, will go to Bradford Hospital because they've got the level 3 with the intensive care provision to complete their practical placements. So that's why we have the challenge of only being able to release a few people at a time to undertake the practical elements of the course.
And my understanding is that in terms of medical support, there is an intention to have specifically obstetric consultants and specifically gynecology consultants going forward. How are things in terms of the establishment of obstetric consultants, substantive posts?
So we have been staffed to the current funded establishment of consultant posts. We've done quite a lot of recruitment across the consultant body as well in the last 12 months. And again, we have had a business case that we've submitted to increase that establishment by another couple of full-time equivalent consultants that's been approved. And it's that bit that will allow us to split the rota. So we're just currently going through the vacancy control processes to advertise those additional posts. Once recruited to, will be fully established and we'll be able to split the rota so that we have dedicated consultant on-call cover for obstetrics and dedicated for gynaecology.
So we do have a separate obstetric and gynaecology rotas. They work independently. We are funded to what we require for obstetricians. There has been a delay in appointing substantively to 2 consultant obstetricians, so we've backfilled with locums for that. There has been a challenge from a locum perspective to get the interest of somebody to come with a purely obstetric job plan. So because of that, those locum posts were advertised as joint gynae and obstetrics, but the Trust are very happy to be able to grow our own consultants. So these are an interim measure, and some colleagues that will be at consultant level by early in the new year will make that transition to the permanent substantive posts once the locums come to an end.
Am I too optimistic in hoping that the vacancy control process at CHFT is more streamlined than when I was there?
So in terms of those frontline clinical posts, they're exempt from the vacancy control process. So we have a cohort of clinical frontline colleagues, which includes consultants and nurses, that are exempt from the vacancy control process.
I'm voting, not putting my microphone on. Can I ask about neonatal services across the region then, because yes, you have your own neonatal services, but there are also tertiary neonatal services as well. And so how are those operating currently, and what impact do you think the National Maternity Review might have? Obviously, though, you can't discuss any recommendations or anything like that that you might think might come through. But what impact is it having on the neonatal services that you have and the tertiary services?
So there is regional pressures across the north in the neonatal services. So across the whole of the north of England, that's been very pressured lately with the limited cot availability. We have been at CHFT to maintain safe staffing and the standards with the BAPMs, the British Association of Paediatric Medicine Standards. We have not been running to our full complement to make sure that we maintain safe staffing ratios. That has impacted on us being able to accept more babies, but it's the right thing to do to maintain safety. But the COP pressures are being managed through the operational delivery network. There are regular meetings being held around the movement of babies, around where tertiary cot availability is. It has required some families in the to move transferred some significant distance for cot availability, and that is challenging and not what anybody would want to see. Those pressures appear to be easing slightly currently, and CHFT has been in a better position over the last week or two in terms of cot availability, but it ebbs and flows, I think it's fair to say, depending on need, but it is managed at a regional level.
Yeah, Wyatt as an organisation of the West Yorkshire Acute Trusts a meeting with the operating delivery network to discuss what any impact over the winter that operationally that might be. So we do have close conversations with them around the operating models to do that.
I think it's just to add as well, you know, we all work collaboratively to support where we can, but with the benefits of having rooming-in rooms within our neonatal services, that is supporting those families that are having to travel some distance for a cot.
Are there any other questions on the Councillor Lawson?
Thank you. I've been looking at sort of the work that you've been doing around antenatal classes. Is last time I actually raised it, I believe that it was still very much hospital based at Pinderfield and at Calderdale. Can I confirm that there is now in-person antenatal classes in both North Kirklees and South Kirklees?
So we are running an in-person class in Huddersfield from the Huddersfield Royal site because we've got room availability there, but as I described, we're looking to expand that, liaising with Kirklees Leisure. There is a funding issue because we have to pay for the hire of the rooms that we would use, so we're just working through where we can source that funding from to support that, but looking at delivering perhaps through Kirklees Leisure. There will be an opportunity with the CDC when it opens to deliver classes through there as well. But we are trying to work differently about perhaps going into those communities in a different way than perhaps what is thought of as the traditional antenatal care education delivery. We are offering the virtual classes, which are proving very popular currently for families.
Yeah, and we're providing a variety of ways to deliver that, at the birth centres. Again, cost funding plays an issue on where we can do that. Our consultant midwife undertakes parent education at Urban House with the Befrienders service there for our women whose first language isn't English. So we're trying to optimise every opportunity that we can to deliver a variety of teaching.
Thank you. What percentage of first-time mothers actually attend the antenatal classes? And also, what work is being done to try and encourage the women that perhaps really should attend?
So I don't have the data with me on the breakdown of first-time mums versus mums who've had a baby before coming to the classes, but I can get that for you. I think in terms of the work to engage with mums, I think it's described around that health inequalities work. So this is how we can do that differently. So working with our community leaders, going into the mosques if we can, and I've moved from an organisation where we did that successfully and delivered parent education classes to that cohort. Antenatal education doesn't have to be delivered as a group class, and community midwives have one-to-one sessions and are at liberty and with autonomy to do that as required for the women that they see. So that trusting relationship is really important in being able to deliver that antenatal education information in a different way to some women, because there will be some women who will never want to access group education sessions, and that's really important. We don't force everybody into that model, so our community midwives are encouraged and have the autonomy to deliver antenatal education in a way that works for their cohort and caseload of women on an individual basis.
I think the other thing to add in there, that we can't be prescriptive, that one size fits all. I think we learned that through COVID as well. We deliver it through 4 different sessions of an evening. We also deliver it over 2 full days at the weekend. But what is evident is people don't want to come to all of it. They want to be able to pick the bits that are relevant to them. We still get, second, third, fourth time mums that might have had a gap between their families and want to maybe just revisit the early labour element of it and not want some of the other bits and pieces. So it's a very eclectic model, and obviously that's the route we're moving down. I think if we could get out into more areas, that would be something to explore, but that's an ongoing challenge we have with our clinics in the communities anyway, but that would be the ideal, I think.
Thank you. I totally agree with you that one size does not fit all, and actually the women being able to build up that trust with their actual midwife, and especially women from sort of more disadvantaged backgrounds. If they've got that trust, they've built up that thing, they will ask the relevant questions. Just one final point on the actual virtual classes that are actually offered. Are they done in various different languages?
Not currently, but we're exploring what technology is available to help us with that, as to whether there are any NHS validated tools that we could apply to that virtual session to help the translation. the maternity befriender role that we've just recruited speaks some alternate languages, so we're just exploring how we can utilise her to help deliver the sessions. And I am making contact with a service called Bradford Volunteer Doulas to look at that model. I'm going to liaise with my colleagues in the ICB about that model because they support delivery of antenatal education in different languages, I understand. So I want to explore that a bit further to see what options we've got. I think moving forward, there may be some AI technology that we can use to help. So there's various things we want to explore. There's been a recent presentation at the National Maternity Safety Conference about the use of AI that I've asked for more information about to help.
Thank you.
Okay, so can I ask then, when you think you will have a decision, one way or the other, on whether you're going to have a birth centre in Huddersfield, what are your current timelines for making such a decision? Because obviously, after you've done the full business case, you are then turning to the space at Huddersfield, then you're going to need a decision on whether there's going to be a birth centre at Huddersfield at some point in the future as to how that configuration at Huddersfield is going to look. So what are your current timelines for saying definitely one way or the other, and what are your timelines for further expanding the services to the Bronte Centre?
So at present, we're not in a position to incorporate the standalone birth centre into the current delivery operational model that we've got for all the things that we've discussed both in the report at the previous health overview and scrutiny committees, and I think that's the answer at the moment.
Okay, so previously you've said, oh, we're reviewing to this, we're reviewing to that, we're reviewing to the other. So what you're saying is at the moment it's staff capacity at the minute that is not there for you to be able to even look to a review at this point in time.
Yeah, not at this point in time. We've seen the complexity of women, the health inequalities that we're experiencing, the priority around continuity of carer, and our ability to offer an addition. So we offer the choice of birthing in a birth centre. What we haven't got is the capacity to do that in 2 birth centres.
Which was my next point as to the expansion of information about the Bronte Centre, and how you are progressing that which you've already said about as to the connections, so that there is a more of a choice without complications of patient records and all that sort of thing, because it is about choice, is it not? And yeah, okay, thank you. Any other points then? No? Can I thank everybody for being with us today, and we will close the meeting there. Thank you.